Good morning, respected chairperson, distinguished faculty and colleagues. I am Dr. Samrat Jankar from Pune, India. Today I will discuss lip procedure and its modification, focusing on one practical question: how can we improve the healing without compromising the continence? LIFT stands for ligation of intersphincteric fistulus tract, disconnecting the fistula within the intersphincteric plane while preserving both the sphincter. I had privilege learning this operation from Professor Arun Rajnasukal, who is the inventor of the lift concept. Lift remain one of the elegant and widely adopted sphincter preserving procedure. However, elegance of the concept doesn't guarantee healing of every patient. The modification I demonstrate today, not the replacement of original operation, they are selective anatomy-driven refinement intended for address specific mechanism of failure while preserving the fundamental principle of sphincter preservation described by the lip procedure. The original lift has been described in 5 steps. The steps are intersphincteric dissection, isolating the tract, secure ligation and division, and confirming the complete disconnection and allowing to heal by the primary intention. Current evidence about the lift is encouraging. ISUCRS strongly recommend lift for transsphincteric fistula. Pooled success is 76%, incontinence is up to 1%. The available evidence is encouraging, but it needs the balance. The question is not whether we can perform lift or not. Why does it lift is most important question. Lip plus is mainly for mature tract. Here proximal lift take out the central part and distal core out reduces a disease burden and help in dependable drainage of the tract. First step, patient in prone position, we do intersphincteric dissection to go properly in intersphincteric space without damaging the sphincters. We isolate the tract in intersphincteric space by using right angled forceps, and we circumferentially dissect, narrow down the tract, and then we ligate and transfix the tract in intersphincteric space by using 20 Vicryl 5/8 needle. The transfixation disconnect the tract, followed by we go for complete division of the tract in intersphincteric space by intersphincteric space. The lower fibers or any residual tract should not be left in intersphincteric space. Complete tract has to be divided so that it get disconnected completely from anal side. Followed by the distal component, we take a stitch and we approximate close the distal tract. Internal opening side, the tract reinforced by using reinforcement stitch. It will add doubly ensure about the slippage of the ligature. Followed by the intersphincteric area what we dissected, we close by using simple stitches. The distal tract, we do distal core out. The intent is to reduce the disease burden. At the same time, it will help ensure dependable drainage of the residual disease and help in healing by secondary intention. Complete distal tract is cored out till the external sphincter without damaging any kind of sphincter injury. The basic principle of lift consists of 3 parts. First one is the secure proximal closure, which will help to control the internal source. External tract management, coring out of the external tract, dependable drainage, prevent further recurrent sepsis. PILTEC is modification of the lift procedure. P stands for proximal disease excision, that is excising the internal opening, mucosa, submucosa. I stands for intersphincteric space clearance, curating the cavity. LT stands for ligation of the tract over the external sphincter, disconnect the tract. C stands for curettage or coring out of the distal tract, lead to dependent drainage. Case number 1, here We had a 32-year-old male who came with a perianal sepsis, scrotal abscess. We can appreciate in the axial, it is starting at the 6 o'clock, 12 o'clock, going across the perineum space and having a large scrotal abscess even reaching up to the root of the penis. We took a patient in prone position. We are doing the intersphincteric dissection, and once done the intersphincteric dissection, we will see the tract isolation. We dissect the tract circumferentially in intersphincteric plane. We divide the proximal disease. We do the proximal disease excision, division of the mucosa, submucosa and internal sphincter, and cauterizing the intersphincteric plane and clearance of the intersphincteric space of infected granulation tissue after proximal disease excision. We ligate the internal opening by using a Vicryl 205/8 needle so that we can take chunk of the external sphincter to narrow down the internal opening. We can appreciate complete secured ligation of the internal opening. Approximate the edges of the intersphincteric dissection, and then we turn the patient in lithotomy, drain the abscess completely. Abscess around 100 ml we drained out. We take a multiple counter incision over the scrotal abscess cavity to drain thoroughly and dependently, and we do the deep perineum space drainage so that the hidden abscess get completely decompressed. We can appreciate skin bridges to avoid the larger incision and dependent drainage. At the end of the procedure, we can see at the end of 2-month complete healing, and also we can appreciate, compare pre and post operative axial MRI. There is no hyperintensity, complete disease has been gone. This is case number 2. We can see in axial hyperintensity located in the perineum space, which is going across and opening at 12 o'clock. We can appreciate which is even extending up to 3 and 4 o'clock. In coronal, we can appreciate a left-sided perianal space collection opening low transsphincteric. Although female anterior transsphincteric, we need to think about sphincter preservation. We have done intersphincteric dissection. We can appreciate the pus is pouring out from internal opening. We have done intersphincteric dissection, and we are reaching in an intersphincteric plane without damaging any internal external sphincter. We are isolating the tract by using a right angled forceps in intersphincteric plane. The tract once get isolated, then the question will come, the proximal disease excision. We are excising the proximal disease, mucosa, submucosa, internal sphincter. We are dividing so that source is taking under control. Source is taking under control. Once proximal disease is excised, then we need to go to the intersphincteric disease clearance. The intersphincteric space cauterized and distal abscess we have drained by taking a cruciate incision. Abscess cavity is decompressed completely. Almost 50-60 cc of pus has been drained. We can appreciate a probe showing the tract. We are excising clearing the intersphincteric space by excising the glandular component, and then although it is a low transsphincteric, but considering female, we are going for sphincter preservation by doing the ligation of the tract over the external sphincter. Once we ligate, then we are going to close the intersphincteric space to narrow down the wound edges to reduce the post-operative pain and increase faster healing. As cavity is large, we are taking a counter incision to drain left ischial space collection also. And we are placing we are debriding, draining, and we are placing a set-on for dependent drainage. Cavity thoroughly debrided, drained, and we are placing the set-on over that. We are placing a 8 French tube for irrigation of the cavity for thorough gentle irrigation. For the post, we can see at the end of 2 months complete perineum healed, and also we can compare pre-operative, post-operative, a post-operative complete resolution of the disease. This is case number 3. Here we see that axial hyperintensity on the both the side extending into the deep posternal space, connecting it internal opening at 6 o'clock position. In sagittal we can appreciate 2 tracts having hyperintensity reaching into deep posternal space, high transpintric connection we can appreciate. On patient in prone position we have done mapping, we can appreciate bilateral horseshoe with extending into the pilonidal area. The first step is intersphincteric dissection and circumferential dissection of the internal opening, and isolating the tract by using right angle forceps and proximal disease excision, making the right angle forceps little bit oblique so that proximal cranial 5 mm distance we can take. We can excise the proximal disease, followed by we do the central disease clearance. As we excise the tract in the intersphincteric space, and if there is a cavity or any abscess or any vertical extension we can lay open. So that's the intersphincteric space clearance. Once we have done intersphincteric space clearance, next step will come to identify where it is going and decompress the deep posternal space. We excise the central disease and then we are decompressing, draining the deep posternal space going from the internal opening, and then we are secure ligating the opening across the external sphincter, that is ligation of the tract over the external sphincter by using Vicryl 20, and then reinforce it with use of mucosa available after first dissection. Now 3 components are over. 4th component is the distal tract. The distal tract is having bilateral horseshoe, one limb is extending into paracoccygeal. All thing we thoroughly open up, drain completely, debride thoroughly, wash and lavage with betadine diluted S2O2 so that the drainage will be done, septic focus will be taken care thoroughly. After that, for dependable drainage, we place the skin bridging set-on. We approximate the intersphincteric area to reduce the pain and healing faster. Skin bridging set-on will help for drainage. This is at the end of 1 week, this is at the end of 2 weeks, this is at the end of 3 weeks, this is at the end of 1 month, and this complete healing at the end of 2 months. But we have done post-operative MRI. MRI is not showing complete clearance of the disease. There is residual hyperintensity in the deep posternal space. Clinical healing at 1 year in 87 high transsphincteric fistula with abscess is 93. Radiological healing is 87%. We opt lip plus for mature tract. Immature septic tract PILTEC we give as an option based on the stage of the tract. To improve the failure by refinement, mapping before operating, controlling the sepsis, technical improvement, and selecting patient optimally and optimizing based on the tract. The success can be improved by mapping the anatomy, controlling the sepsis, secure disconnection of the source, tailoring the procedure to the disease. Lip plus and PILTEC are anatomic driven refinement, not the competing to the procedure. These are the just option to the lift.